Good morning, everyone. This is Karina Hill with the Florida Alcohol and Drug Abuse Association, and I would like to welcome you to today's webinar. Hope you're enjoying the nice, cool weather this morning. Today's webinar is entitled Stigma, Substances and Policy, How Language Drives Change with Dr. John Kelly. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and myself by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Again, please use the chat panel to send any questions you may have as you think of them, and I will be curating your comments and questions, and the presenter will address them as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are also posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and calling using the telephone I will call in option. You must be connected to both the audio of this presentation and also be logged in to view it online as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. However, we did post the link for the PowerPoint in the chat panel, and it's also on our website if you would like to print those prior to the presentation. The archive video in our training library displays what looks like to be an error message, but it's only a delay buffer, so just ignore it, hit play, and enjoy. To access the recording and PowerPoint, you can go to our website, www.fada.org, and to our Resource Center training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Friday, December 4th. Your feedback is very important to us, so please make sure you do complete the evaluation. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register for the first time. Please note that WebEx does monitor your arrival and departure, and it provides a report upon completion of the event. So it's very important that you attend the entire webinar to receive credit. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And with that being said, I'd like to introduce our presenter. Dr. Kelly is with the Elizabeth R. Spaulding Professor of Psychiatry and Addiction Medicine at Harvard Medical School. He is the first endowed professor in addiction medicine at Harvard. He is also the founder and director of the Recovery Research Institute at the Massachusetts General Hospital, the Associate Director of the Center for Addiction Medicine, and the Program Director of the Addiction Recovery Management Service. Dr. Kelly is a former president of the American Psychological Association, Society of Addiction Psychology, and is a fellow of the APA and a diplomat of the American Board of Professional Psychology. He has served as a consultant to U.S. federal agencies and non-federal institutions, as well as foreign governments and the United Nations. Dr. Kelly has published over 200 peer-reviewed articles, reviews, chapters, and books in the field of addiction medicine, and was an author on the U.S. Surgeon General's report on alcohol, drugs, and health. His clinical and research work has focused on addiction treatment and the recovery process, mechanisms of behavior change, and reducing stigma and discrimination among individuals suffering from addiction. And Dr. Kelly, if you're ready, I'll go ahead and pass the presentation over to you.
Sounds great. Thank you. Fabulous. Well, good morning, everybody. I hope you can hear me clearly. Delighted to be with you this morning. Karina, thanks so much for the kind welcome and introduction. Let's get right to it. Today, I'm going to be talking about this issue of stigma. And of course, whenever we're talking about addiction, substance use disorders, and mental health, we are also talking about stigma and discrimination because they go hand in hand, unfortunately, with these conditions. So I'm going to talk to you today about what we've learned about stigma and how we can address it and how important language is in terms of how we discuss these problems, people suffering from them, and the nature of them. So I'm going to give you a little bit of history in terms of how we've come to this point in time right now where we're thinking and looking more squarely at our language and terminology and how it pertains to stigma and discrimination. And I'll put that in context for you. So this is just a bit about me here. I don't have any conflicts of interest. And so, one of the things that I've been reflecting on recently is the fact that we are at this 50-year milestone since the declaration of the war on drugs under Nixon and the Nixon administration. So a lot's happened, of course, in this 50-year time period. We associate typically this declaration of the war on drugs with kind of punitive, harsh rhetoric. And of course, the language of the war on drugs is one of a militaristic kind of approach to addressing punitive measures to people. This has not worked in the way that it was intended or hoped. But in addition to the harsh rhetoric was also a lot of federal appropriation of funding, which actually funded and started the National Institute on Alcohol Abuse and Alcoholism in 1970, and also a few years later in 1974, the National Institute for Drug Abuse. About a decade or so after that, the Substance Abuse and Mental Health Services Administration was formed to disseminate evidence-based treatments and the new knowledge that was being produced by the research coming from and funded by NIAAA and NIDA. And we've really learned a lot. And what I'd like to do is just kind of give you a little bit of an overview of some of the things that we've learned about addiction and substance use disorders and how that relates then to this issue of stigma. Because stigma, of course, is produced in part by beliefs about causes and controllability, and I'll talk more about that. But one of the things that we've learned in the last 50 years in relation to cause and controllability is how substance use disorder and addiction is caused. We know now more than we've ever known about addiction and its genetic contribution. We know roughly half the risk of addiction is conferred by our genes, by our blueprint in our genes. So that makes some of us more susceptible, some of us less susceptible to this complex disorder, in the same way that we would be susceptible to other kinds of diseases and disorders from which human beings can suffer. Now, the other thing that's very important to know is that it's not just genetically determined. It's genetically influenced, but just because you have a genetic predisposition does not mean you're going to manifest the disorder. And this is very important in terms of prevention. But it's what we call a complex or multifactorial disorder, which, of course, as I mentioned, genetics play a major role, but also it's multi-determined. It's the interaction of our genes with the environment over time. And this is why there's so much emphasis on preventative measures, things that we can control to prevent exposure, prevent stress in the early home environment, and stresses, abuse, and neglect of children. Things like that, which can cause stress, which can turn on through epigenetic factors, turn on certain genes, which can produce disease and disability down the road. The other thing, of course, is drug exposure, as shown here. The earlier the onset and exposure in the human brain to drugs that can cause addiction, the greater the likelihood, independent of other factors, greater the likelihood that somebody will become addicted to a substance. And of course, exposure plus these other factors changes the brain. And it's those brain changes, of course, structurally and functionally, which contribute to alcohol use disorder or other drug use disorders. Another major thing we've learned, of course, is from neuroscience, not just genetics. Genetics kind of pertain to cause. Neuroscience has given us clues about how drugs affect the brain. And this has been very important in terms of understanding this factor of neuroplasticity. That is, that the brain changes as a function of learning and exposure. Exposure, in this case, to neurotoxins in the way of alcohol or other drugs, which can actually change the structure and function of the brain. And this has been very important to understand in terms of stigma, because this pertains to controllability. Right? You can think about genes are to cause as the neuroplasticity is to controllability. And we understand now much more clearly how the brain is affected with chronic exposure to substances. The brain tries to adapt and change as it is exposed to these abnormally high levels of reward and reinforcement. And over time, what happens through this processes of neuroadaptation and neurotoxicity, which includes cellular death, is that people's ability to regulate the impulse to use a substance becomes radically impaired, so much so that a human organism can actually poison itself to get to death, on average, for people who suffer from addiction, roughly 30 years earlier than Mother Nature intended. So there is some kind of medical malfunction now we clearly see through neuroimaging that occurs in the brain, both structurally and functionally. And this has major implications for understanding the nature, the true nature of substance use disorder and addiction, which addiction is the more severe form of a substance use disorder. Not only that, of course, we've learned a lot about epidemiology, which particular factors elevate risk for a substance use disorder. This has been very important in terms of understanding how other psychiatric illnesses can elevate risk, other environments can elevate risk, age of onset can elevate risk. All of these other factors have been very important to learn. We've learned this all in the last 50 years. We've also learned about recovery. This is a national recovery study that we conducted a few years ago now, estimating the prevalence of recovery, not just those with substance use disorder, but those who've actually resolved a significant alcohol or other drug problem. And we have estimated, which is consistent with other regional estimates, that roughly 22.35 million people, or almost 10% of the U.S. adult population, have resolved a significant drug or alcohol problem. The way that they do that also, we've recognized, is through multiple different pathways. I think our cultural default in terms of understanding how people recover from an addiction problem or substance use disorder is through treatment and mutual aid organizations and medications. But actually, roughly half or more of individuals who resolve a substance use disorder do so without the help of any kind of formal treatment service. So that's interesting. It's important to know from an epidemiological standpoint that many people can and do recover without external services. Those individuals tend to be less severely impaired and less severely drug involved and have more what we call recovery capital. That is to say, more recovery resources at their disposal to which they can turn to help them in a recovery attempt. Another thing that we have learned is that people go through stages of drug involvement and change related to that substance involvement. And some of you may recall this from the 1980s, this idea of the stages of change is kind of lost, it's kind of out of fashion at the moment because it's not novel, but nevertheless, it's a useful heuristic to understand exactly where people might be in the change process so that we can intervene and meet people where they're at rather than assume that they're at a certain stage and find ourselves frustrated as clinicians when people aren't moving in the way that we would hope. This, of course, has had a major influence on different interventions, particularly this notion of pre-contemplation and contemplation. That is to say, when people themselves are not that motivated or don't see a significant drug or alcohol problem, even though other people may see it in their close family environment, for example. They can see it usually long before the person themselves can see how alcohol or other drugs may be influencing and impacting their life, because it starts to affect those other people in the environment much sooner. And of course, that notion of the stages of change has played a major role in the foundation of motivational interviewing. As Bill Miller says, what people really need is a good listening to. I think prior to the 1990s, I think we all thought in the clinical world that what people really need was a good talking to. And as if we could confront people. This was the major modus operandi of treatment, was that you needed to confront people and to confront them even harsher and more toughly if they didn't respond. On the other hand, what motivational interviewing did was really recognize this period or this stage of change of pre-contemplation and contemplation to really sit with the person, to help them think through what some of the consequences of their use might be, help them resolve ambivalence about change, to help them move them in the right direction. Related to that a little bit before that, actually, was this notion of relapse prevention. This came along in the 1980s, a little bit before motivational interviewing. But the idea here, as epitomized by this quote by Mark Twain, attributed to Mark Twain, "Quitting smoking is easy. I've done it dozens of times." The idea, of course, here is that, yeah, quitting, people can quit, people can stop, but how do people maintain that behavior change? And this is where relapse prevention really was a major contribution back in the 1980s, in understanding that we need to teach people the skills, the living skills, how to prevent relapse, how to cope with the demands of recovery over time. And this is where this was particularly helpful and important and significant. Other things that we've learned in the last 50 years that have contributed to stigma and discrimination have been contingency management. Very powerful studies, about 150 now randomized controlled trials showing that swift, certain, modest, positive consequences can help shape behavioral consequences, help people stay engaged in treatment. We've had now a ton of research sponsored by the NIH looking at mutual help organizations, particularly the big one, Alcoholics Anonymous. And we've just published a review, actually, in the Cochrane Library, which is considered to be the gold standard of academic medicine, showing the benefits of Alcoholics Anonymous and 12-step treatment as it pertains to alcohol use disorder in terms of producing equal or better outcomes, particularly in terms of helping people sustain remission over time while reducing healthcare costs substantially. So big insights have been learned about the need for continuing care in this regard, in terms of continuing care and recovery management. Very importantly, in the opioid crisis, we've had effective medications which can reduce overdose deaths by 50%, particularly buprenorphine and methadone. We also have naltrexone, an opioid antagonist, as well as FDA-approved medications for alcohol use disorder, which of course accounts for about 75% of all addiction cases. So alcohol use disorder is the big one in terms of overall substance use disorder cases. but in terms of lethality, both are lethal, alcohol and opioids. But we've had a huge increase in opioid overdose deaths, sadly. But we have good, effective medications that can help people stabilize and help them on their way to recovery. Harm reduction strategies have also been very, very important in terms of reducing overdose deaths and also the transmission of infectious disease. The idea, again, here is to try and meet people where they're at, to engage them, to help offset a deleterious ongoing trajectory of addiction. As I've mentioned with mutual help groups like AA, NA, Smart Recovery, and the like, there have also been clinical efforts to engage people over the long term, because we understand now much more clearly the susceptibility to relapse over time. And this is why continuing care and what we call disease management or recovery management, the idea that we need sustained, ongoing efforts to help engage people, help maintain people over time. And I mentioned as well, at the beginning here, this idea of the war on drugs and how our terminology has shifted and changed in the last 50 years. I don't think we would describe drug abuse, quote unquote, as public enemy number one today, but we might refer to it instead still as the top problem, which it is. It's still the top problem in this country, but we would describe it as the top public health problem. And that is an important shift in the way that we conceive, that we conceptualize these problems, and therefore how we actually address them. Our laws over the last 50 years also reflect this shift away from the punitive rhetoric, harsh policies of the war on drugs towards more public health-oriented efforts. You can see here on the left-hand side the Initial Controlled Substances Act as well as the Anti-Drug Abuse Act, which incorporated mandatory minimum sentences which disproportionately affected Black and brown individuals, particularly young men, and put them in prison for long periods of time. It increased the prison population but did not decrease drug use and drug use disorders. This has shifted in recognition of the lack of efficacy of those initial efforts towards greater emphasis on what we call demand reduction, which is really prevention, treatment, and recovery. And importantly, this has meant access to care. There was a law passed called the Mental Health Parity and Addiction Equity Act, the idea of which, of course, is to place mental health and addiction care at parity with other kinds of physical illnesses for which people are able to get insurance coverage and get treated, but to put that on par with those other disorders so that people could get access to treatment. And then the Affordable Care Act came along a little bit later, which made addiction, substance use disorder, an essential health benefit. That meant if you were an insurance company, you had to cover substance use disorder as an essential benefit. And these more public health-oriented laws were designed to, again, to help address this number one top public health problem in this country, and in fact in most middle and high-income countries around the world. There's been a shift also in criminal justice. I was privileged to be at this first ever National Drug Policy Reform Summit held at the White House in 2013. And Gil Kolakowski, who's actually featured in this picture here that you can see, he was a former police chief, and he became our drug czar at the time, and was the head of ONDCP, the Office of National Drug Control Policy. And under that administration, was very responsible for underscoring a market shift in policy away from the harsh rhetoric of the criminal justice approaches to the war on drugs toward a broader public health approach, which appropriated disproportionately more money towards, or proportionally more money towards demand reduction. That includes prevention, treatment, and recovery. So our criminal justice approaches, our kind of war on drugs approach has shifted emphasis away from criminal justice. I was actually at the United Nations in Vienna in January talking about this very topic of stigma and discrimination worldwide. And interestingly, when I came out of the building here, I noticed this monument. This is the only monument outside of the United Nations building in Vienna. And you can see here it says dedicated to all those affected by drug problems worldwide. Drug problems are preventable and treatable. I think a very important monument dedicated to all those individuals and families suffering from drug problems worldwide. That people are aware, people want to change things because our approaches, even worldwide, have not been where they should be. Think about the drug courts too, the shift away from criminal justice approaches through drug courts, again, related to the idea of conceptualizing, understanding these disorders that we've learned in the last 50 years from the NIH research, that these are medical disorders, that they affect the brain's neurocircuitry, that they affect decision-making and impulse control. And therefore, if we can actually use the leverage of the criminal justice system to help people whose crimes are driven by that impulse control related to drug use, we're actually more likely to get the effects that we want in terms of helping people stop crime and get back into real life. And so drug courts have come along. Who'd have thought this would ever happen? Police officers on the front line recognizing that people need help, not handcuffs. This was made headline news around the country back, I forget how many years it was now, it must be 7 or 8 years ago. Chief Campanello in the Gloucester Police Department and the North Shore of Massachusetts, here a few miles north of where I am today, figured out that, we can't lock people up, because if you lock people up, they just come back around if they're addicted. We need a better way to address the problem that's driving the behavior, which was in this case addiction. And so he ended up starting this thing called the Angel Program, the idea of which was that if people came into the police station who had an addiction problem, they would take them to treatment, not to jail, get them involved and engaged in treatment. How fantastic is that in terms of being able to recognize these problems right at the front line? And these police officers, of course, were exposed to these individuals day in and day out. And so they knew too well that what they were doing was not working. So they tried a different approach. And this has now become more mainstream around the country and is gaining momentum as we recognize kind of the true drivers of many of these problems. I mentioned already that, that stigma and discrimination, I was talking to a reporter this morning about this very issue, that stigma and discrimination, of course, are very important when we're talking about drug and alcohol problems for a number of reasons. One is that it prevents people or delays people in their help-seeking initiatives. And we know that this timeline, we can shorten this timeline. This is the timeline in adults with severe addiction problems, the people that we see in specialty care treatment settings. We know on the left-hand side here, for example, that it takes 4 to 5 years after the onset of a substance use disorder before people start seeking help. 4 to 5 years after the onset. So that's after they already meet criteria for a substance use disorder before they start seeking help. Why is that? Why do they delay? Again, part of it is certainly people want to try and see if they can control it, try all kinds of ways to try to control their use. But also, there's a lot of fear, shame, stigma, self-loathing that goes along with these disorders, which is perpetuated and reinforced by society's attitudes, what we call structural stigma, public stigma. So there's a lot we can do there in terms of more screening in primary care and other settings where people will find themselves, and make it a routine part of healthcare. What's also important is that when you look at this timeline, is that the time it takes to get to remission after people start seeking specialty care takes about 8 years in adult samples and about 4 to 5 treatment episodes. So that's quite a long time before people get that first full year of sustained remission after they start seeking care. And most of those days are abstinent days, but they might, on the first attempt, they might get 3 months, have a relapse. On the next attempt, they might get 6 months, have a relapse. On the next attempt, they might get 10 months of abstinence and remission and have a relapse. But until they get that one full year of sustained remission, it can take up to 8 years. What's also noteworthy on the right-hand side here is that even after people achieve that first year of full sustained remission, which is a big deal, getting that first year, it takes an additional 4 to 5 years of continuous remission before the risk of meeting criteria for a substance use disorder in the following year drops below 15%. Why 15%? Because 15% is the annual risk in the general population. So to be no more likely than anybody else in the general population of meeting criteria for a substance use disorder in the following year, if you already had it, it takes 4 to 5 years. So that's a long time. And this is why we talk about addiction as an illness which is susceptible to relapse over the long term, even when people achieve that first year of sustained remission.
Dr. Kelly?
Yeah.
Oh, I'm sorry to interrupt. I do have a question from the audience if you have time.
Yeah, sure.
I have a question. Do you know of any studies that have been done on the fatality rate of methadone overdoses or the long-term addiction thereof? I have known several individuals over the years personally that have passed due to overdosing on methadone, but have yet to find any studies that have taken place in regards to this. I've also asked multiple presenters who bring up methadone as a positive for MATs, yet no one has a statistics on this. If you do know where I can get this information, I would be forever grateful.
Mm-hmm. Yeah, the CDC usually is an excellent source for the studies that document overdoses, and they will have, or they should have, I'm pretty certain they do. I'm 95% confident they have the data on methadone attributable overdoses as well. So methadone can cause overdose, and they will have those data there, the CDC. So if you go to cdc.gov, I don't have them at hand. So they can, like any opioid, full agonist opioid, it can cause overdose. The good news is with methadone is that it can help people stabilize and get into remission and recovery exceptionally well, as well as reducing overdose deaths. So even though for some people it can cause overdose, you've got probably 90% probability that you'll prevent overdose deaths from methadone. So that's the good news. But thanks for the question. So the point here is that this delay in help seeking. The other thing is that not only does it affect delay and people avoiding help seeking because of the shame that they feel related to stigma and discrimination, but it can lead to earlier termination and dropout from treatment, and I'll talk about that. So I'm going to talk more squarely now about stigma and discrimination and what we've learned about that in particular as it pertains to substance use disorders. So what is stigma? Stigma is an attribute, behavior, or condition that is socially discrediting. What is discrimination? Discrimination is the unfair treatment of individuals with that particular stigmatized condition or problem. Sometimes we talk about those as the same thing, but stigma is the condition, discrimination is the unfair treatment of people who have that condition. And there are different consequences, as I've been alluding to a little bit already, related to stigma. And these can be both public and personal. Public stigma, of course, can lead to differential public and political support for different policies. As I mentioned, we've had more emphasis on the punitive, harsh rhetoric and approaches of the war on drugs until recently, where there's been a shift in broadening the base of approaches to include more demand reduction, prevention, treatment, and recovery support services. And there's been more public support for those, particularly in light, more recently, of the opioid crisis, sadly. Related to that, of course, is this differential in public and political support for criminal justice preferences. It can lead also to barriers to employment, education, and training, what we call macro discrimination, or the inability for people to get a job who've had a drug history, or to get a loan or get training or education. Same with housing and other social support, access to social services, and increased social distance because people are perceived to have the problem to be dangerous. In terms of, yeah.
We have another question. If you were to control the general risk in the population, would the timeline change significantly?
If you were to control?
For the general risk in the population. Maybe that person can reword their question and send it to me. I have a comment. The annual FDLE Drugs and Disease Persons Report breaks out methadone as a cause of death or present in death statewide and by region. And then I guess this person just responded, isn't methadone therapy most effective in combination with substance abuse counseling?
Yes, it's actually required. It's required, typically, methadone is required along with counseling at least once a month. That's a best practice. Yeah. Yeah, so, yeah, all those things are important. I'm not sure in terms of the timeline question exactly what the person's pertaining to. I think the key thing there with the timeline is to recognize there are things that we can do to shorten that. That's the important thing, is that this is not an inexorable time course of the illness. It's rather that we know that there's things that we can do to intervene earlier to prevent an ongoing or developing hardening addiction pattern through earlier intervention. And this is so key when we think about this as our top public health problem, that we can start to intervene before people are really seeking treatment themselves in primary care, in other mental health care settings where people with addiction problems are also attending, have visits. So starting this earlier, greater education and prevention in schools. These are key facets and factors that can help shorten and diminish the onset of substance use disorders, as well as being more assertive when people start treatment, to attend to not just the clinical pathology, but to attend also to the resources that people need to be able to help them on their recovery journey, what we would call recovery capital. This is access to housing, to jobs, to education, to training, to the kinds of things that people need to help them get some traction in recovery. Even NIDA now, the National Institute of Drug Abuse, recognizes that effective treatment programs not just attend to the clinical pathology, but provide all of these other services in the most effective treatment programs to address housing needs, legal needs, family needs, all these other needs, which we wouldn't think readily and immediately pertain to a clinical phenomenon of addiction. But what they recognize, and which we all, I think, really need to recognize, is the need to address not just clinical pathology, but these other social determinants of health that can help people get traction in the recovery, including the building materials that they need to rebuild their life. And most importantly, a building permit. They need the building permit to start to rebuild their life. And that means that they need to address their past criminal history and be able to get back on track and get a job and get housing, get the things that they need to be able to function normally in life. Just think what that can do in terms of hope. So related to that, of course, is this personal aspect of stigma, which, the internalization of public stigma can lead to, as I mentioned, the shame, the self-loathing, the fear of discrimination that people often experience, lowered self-esteem, the delay and avoidance of help seeking, and also less treatment engagement and retention and lower chances of remission and recovery. And the commonly studied dimensions of stigma are these: blame. So are they responsible for causing their problem? Remember, I was talking at the beginning about what we've learned about addiction and substance use disorder as being multifactorial, but having a strong genetic influence. So some people are more vulnerable just by virtue of their genes. Some people are protected just by virtue of their genes. Prognostic pessimism or prognostic optimism, what does that mean? This is another dimension of stigma that is studied, and that pertains to, will they ever get better? can someone with a substance use disorder actually recover? Can they be trustworthy? And this is very important when we consider stigma, because that can lead to social distancing. And not the social distancing we're talking about under COVID, but avoidance of people because they're perceived as dangerous and unpredictable, which are other dimensions of stigma that have been studied. So you've got these 4 common dimensions of stigma which have been studied. And what do we know about stigma as it pertains to substance use disorder and addiction? Well, this was a study done by the World Health Organization across 14 different countries and 18 of the most stigmatized conditions. This included things like having AIDS, being HIV positive, being a criminal, but it also included illicit drug addiction and alcohol addiction. Universally, across these 14 countries, the top-ranked, most stigmatized condition was illicit drug addiction. Number 4 in the list was alcohol addiction, okay, the illicit drug. But think about that. Out of all those different conditions, which are heavily stigmatized in different societies, number 1 was illicit drug addiction. Number 4, alcohol addiction, out of this list of 18 different conditions. So very highly stigmatized in terms of different societies' attitudes towards these problems. And I'll talk about why more specifically. I've alluded to that already. But what studies have shown in relation to substance use disorders, which of course is a psychiatric disorder. It's in the Diagnostic and Statistical Manual of Mental Disorders. Substance use disorder is a big section in that manual, of course. So it is a psychiatric illness, but compared to other psychiatric illnesses, it's bottom of the barrel in terms of stigmatization. So, and lots of studies have shown this. In part, it's because people with substance use disorder are viewed as more to blame for their condition. Why? Because it involves some elements of initial choice. As I mentioned, people aren't aware when they are drinking their first drinks of alcohol or smoking marijuana for the first time or being exposed to another drug, which they might use because other people are using it in their peer group, and so they're exposed. They don't know how they're experiencing it compared to other people. What they do know is that they are experiencing at a much more profound level. And it's that profound impact that which is genetically modulated, which leads to repetition, re-exposure, and the desire to repeat the experience more than other people. But people don't realize that they've had that greater experience. They just know, wow, that feels good. I like that. I want more of this. I want to repeat this. And so that experience can lead to greater exposure. People don't know they're already on the path to potential problems down the road because they just don't realize it themselves. Now, describing substance use disorder as treatable does seem to help. And individuals themselves who hold more stigmatizing beliefs about substance use disorder are less likely to seek treatment and discontinue sooner. And this is important because independent of how severe you are, if you hold more stigmatizing beliefs yourself, even if you're a sufferer, irrespective of how severely addicted you may be, you're more likely to drop out of treatment and to discontinue treatment sooner. So your own beliefs about it influence your own chances of remission and recovery. Now, very importantly, the bottom left here is that there's now dozens of studies which have been done looking at clinicians. And just like other people in the general public, clinicians are also susceptible to biased attitudes against people with substance use disorder. They can view substance use disorder, they've been shown to view people with substance use disorder as unmotivated, manipulative, and dishonest. What does that do? That can lead to avoidance of appointments, shortened appointments, want to get them out of your office sooner, substandard care, not as much compassion or empathy or engagement, when that's exactly what people do need. Greater empathy, as shown with the client-centered approaches espoused in motivational interviewing, for example. Now, we do know that substance use disorder-specific education and training helps. So people who have psychiatric training, for example, in mental health, compared to physicians or clinicians that don't have that training, are more likely or less likely to hold those stigmatizing attitudes towards people with addiction and substance use problems. So why is it that addiction and substance use disorder is so stigmatized compared to other social problems and health conditions and other mental health illnesses? Well, I think it's related to this notion of that initial exposure. With a substance use disorder, unlike schizophrenia or other mental health conditions, you actually have to take something outside of your body, into your body, that produces these brain changes. Now, as I mentioned, we know there are lots of biological and genetic reasons why certain people are more susceptible than others. We've learned that in the last 50 years. That's been very important in terms of etiology. But it pertains to these two factors, I think, related to that, as I mentioned, which are cause and controllability. Typically, when we think about stigma and discrimination, if we can say that it's not their fault and they cannot help it, stigma tends to decrease. If, on the other hand, we say, yes, it is their fault, and really, yes, they can help it, they're just engaging in kind of selfish, willful misconduct at the expense of others, stigma tends to increase. And I think this is why substance use disorders are particularly stigmatized relative not just to other health conditions and other social problems, but also to other psychiatric illnesses, because this issue of cause. And this graph just highlights those two factors in relation to stigma. Now, as I mentioned, we already know that, and we've learned in the last 50 years, the genetic influence. Roughly half of the risk for addiction is conferred by our genes. Doesn't mean it's genetically determined, but it's strongly genetically influenced. And people are not aware of the fact that they are on a path when they're exposed earlier on in their life, that they are on a path to an addictive process. Now, we can do better. I think we can start to identify those at risk and intervene earlier. Like I said, we can potentially offset cases down the road, as well as prevent prolonged cases. We don't have to wait for people to get to stage 3, stage 4 addiction before we do something about it. We can intervene earlier, identify and intervene earlier. This has been very important. Now, one of my colleagues asked the question, he says, the question should be not why do people become addicted, but how come we're not all addicted when 90% of the population in most middle and high-income countries are exposed to addictive psychoactive drugs like alcohol. Now, alcohol is by far and away the largest contributor to addiction. 75% of addiction cases in the United States are alcohol addiction, right? But of all those exposed, only about 15% of people who are exposed to alcohol actually become addicted. And again, the reason why is in large part because certain people are more vulnerable than others, just by virtue of their genetic and biological makeup, as well as the developmental history, which of course has epigenetic effects on the human genome in turning on genes or turning off genes. So that's in terms of cause. And as I've alluded to already, we've learned a lot about neuroplasticity and controllability. Now, these neurocircuits we've identified now very clearly are involved in addiction: reward, memory, motivation, impulse control, and judgment. All of these areas here are effective, both in the subcortical areas of the brain, the limbic system, where our memory is and our reward system is, and also our ability to appraise risk and inhibit impulses to use. All these areas of the brain, we know now very clearly, are impacted, and they can be radically impacted in a dose-response fashion as people are exposed to substances over time. Not just functionally, you can see structurally. When you look at structural images, magnetic resonance images, you can see that there are structural changes in the brain of individuals who are exposed chronically to substances. You look on the bottom right-hand side here. You don't have to look very long or very hard to see this major difference. It doesn't look particularly healthy, that brain on the right, compared to somebody who's a moderate drinker. Someone on the right here is exposed to alcohol more chronically and heavily. shows this typical pattern of this ventricular enlargement and cortical shrinkage on the outside of the brain, which of course helps us understand when we see things like this, these images more readily. Wait a minute, why is it that somebody would swear off their drug and say, this is the last time, this time I really mean it, this time I promise I'm not going to do it again, only for them to break that promise to themselves and to other people? It's in large part because of their inability to follow through on that initial decision. In part because these brain changes have gone on. We understand that much more clearly in terms of both cause and controllability. So what can we do about stigma and discrimination in addiction? Well, I think there's three major things that we can do to address it. One, I've alluded to already. We know, for example, that with clinicians, that clinicians in the healthcare system who are more educated, have more training around addiction and mental health, tend to have less stigmatized and discriminatory behaviors towards individuals who suffer from substance use disorders. So education can help. There are a few twists to that, which I'm going to tell you about in a few minutes, about education and what we need to do there. Personal witness is another way that stigma can be addressed. The idea of putting a face and voice on recovery. Some of you may know and even belong to this big organization called Faces and Voices of Recovery. The idea here is to help dismantle stereotypes and stigmatized stereotypes around people, what someone who is a, quote, addict looks like. I think, society has a certain view, a certain stereotype or stereotypes that pertain to people with addiction problems. So the idea is to put a voice and a face on recovery, to talk about recovery, to come out of the closet, as it were, and begin talking about in public that someone had a history of drug or alcohol problems and that they're now in recovery. And that has been very helpful. And in fact, one of the most effective ways of addressing stigma is putting a face and a voice on recovery and that idea of personal witness. Another important aspect, which I'm going to talk a little bit more about in detail, is our language and terminology, because our language and terminology not just reflect our approaches, but they affect our approaches going forward. And I think if we want addiction to be addressed, we need a language that's unified and that really reflects the true nature of what we've learned in the last 50 years regarding substance use disorders and its effect on the brain. So what about education? So here's a question: is if we were to emphasize, as I've been doing, these biomedical factors in terms of etiology, the causes of addiction, and the controllability of substance use behavior, which we know is radically impaired and affected with people who are exposed chronically to drugs. If we were to emphasize those factors, would we actually help end stigma, reduce stigma? What would happen? So this is an important question, and I think we would all think, well, wait a minute, well, if we do emphasize the fact that these are these things, obviously they affect the brain's neurocircuitry are affected. Yes, we can see that now. We can see that. But what would happen if we really emphasize that? Interestingly, they've done a lot of work in the mental health field regarding factors of cause and controllability. Now, here is a quantitative summary. We call this a meta-analysis. It's a meta-analysis or quantitative summary of 28 different studies combined. So we looked at them all together and looked at studies where they emphasized the biomedical or biogenetic explanations of mental illness. This was not addiction specific, but rather mental illness specific. And what they found was when they emphasized, in all of these studies, when they emphasized the genetic components, the biogenetic component as contributing to the mental illness, it did actually reduce blame. So there was an overall effect on reducing blame for people with mental illness when they emphasized the genetic contribution, which is major for mental illnesses. However, here's the kicker, here's the flip side, which was not expected, is that it actually had the opposite effect on other kinds of stigma, which included social distance, dangerousness, perceived dangerousness, and prognostic pessimism. So interesting, it's a bit nuanced, right? Is that, yes, on the one hand, we can reduce one type of stigma by emphasizing the genetic influence, but we may be increasing other kinds of stigma in terms of pushing people away, keeping them away from us, who may have these problems because we perceive them to be dangerous, and we perceive them as not being able to get well. What about neurobiological explanations? So you can think about this in relation to controllability, okay? So genetics are to cause, as neurobiology is to controllability, or the ability to regulate impulses to act. Interestingly here's another quantitative summary, a review of dozens of studies, about 26 studies in this review, looking at the same thing, same kind of idea here. If we were to emphasize the neurobiological explanations, what would happen to these aspects of stigma? And again, they broke up the different aspects of stigma: social distance, dangerousness, prognostic pessimism, and blame. What they found was that when they emphasized the neurobiological explanations in mental, again, this is in mental illness, not in addiction per se, but what they found was that it actually increased perceived dangerousness and social distance, decreased prognostic optimism, or increased prognostic pessimism, whichever way you want to look at it, and it had no effect on reducing blame when we emphasized the neurobiological. Interesting. So, and not what we would hope for or expect when we think about these disorders. So that's important to know, because if we're going to emphasize biogenetics or neurobiology as a way of reducing stigma, again, this idea of education, then what's that actually going to do to stigma? Well, when you look at mental health and mental illnesses, it tends to reduce blame when we talk about biogenetics. That's in one way good, because we emphasize the genetic influence. But the neurobiology seems more neutral. It doesn't seem to be having the intended effect, or actually it could have the opposite effect. It may backfire. What about addiction specifically? This is a study specifically, we just completed this study. It's just published online in Addiction, in the journal Addiction. In this study, we did the same thing. We looked at different ways of describing and emphasizing addiction. In this study, which was a national randomized study of about 3,600 U.S. adults who are nationally representative of the United States population, here we randomly assigned a vignette describing a person in treatment with opioid-related impairment. But the opioid-related impairment was described in one of these 6 different ways. So you can think about these as being kind of more biomedically oriented to less biomedically oriented. So we had one set of vignettes which described the person as having a chronically relapsing brain disease, another set of vignettes that described the person as having a brain disease, another in which the term that was used was just disease, another in which the term was just illness. The opioid impairment was described as an illness, another in which the opioid impairment was described as disorder, and then the final one was described, the opioid-related impairment was described as a problem. So these 6 different terms, and I thought that these were kind of graded towards, more biomedical, going down to less biomedical. And each one of these was embedded in the same vignette, and the vignette was distributed at random to 3,600 U.S. adults who are representative of the U.S. population. And this is the vignette. Alex, we also looked at sex, by the way, because Alex was used as a man or a woman. So in half the vignettes also, Alex was described as a man. In half, the person was described as a woman. And so this was the vignette that people got. Alex was having serious trouble at home and work because of, I'll use the male version for now, because of his increasing opioid use. He is now in a treatment program where he is learning from staff that his drug use is best understood as and then the term was inserted there, one of these terms, that often impacts multiple areas of one's life. Alex is committed to doing all that he can to ensure success following treatment. In the meantime, he has been asked by his counselor to think about what he has learned with regard to understanding his opioid use as and then the term again was inserted. So those 6 different terms were randomly assigned in that vignette to 3,600 different individuals. And what did we find? Interestingly, again, nuanced findings as it pertains to addiction. What we found, you look at the top figure here, when we looked at the stigma blame score. So remember I told you earlier just now about the fact that when in the mental health field, that when the biogenetics were emphasized, blame tended to decrease. Found the same thing here. So arguably, by using the more biomedical term. So when the person was described, the opioid-related impairment was described as being a chronically relapsing brain disease, you can see here on the left that blame was significantly lower than it was virtually with any other term. So there's something about using that term, chronically relapsing brain disease, which reduces blame attributable to the same person. Now, here's the other interesting finding, however. Similar to the mental health findings, is that it has the opposite effect in terms of prognostic optimism. So when you describe someone as having a chronically relapsing brain disease, yes, it reduces blame, but it also reduces, unfortunately, prognostic optimism. People think you cannot get well if you have a chronically relapsing brain disease. And conversely, if you use the term problem, opioid problem, as opposed to describing the drug-related impairment as a chronically relapsing brain disease, you're more likely to believe that that person can recover. So interesting. Again, nuanced findings. What does it suggest? It suggests that there's not one specific term that we can use to address all clinical and public health needs, but rather we may need to be more thoughtful about specific terms to use in specific circumstances or in certain communications to reduce stigma. When we want to emphasize or reduce the blame, we may want to use more biomedical terminology. When we want to emphasize the chances that people can and do recover, which of course we know is very true with substance use disorders, most people who have a substance use disorder will eventually achieve remission, 75% of them, that we need to get that across. So maybe dropping the biomedical terminology and adopting more general terminology may actually help to increase prognostic optimism and decrease perceived danger and social distance. I think also in terms of emphasizing, when we do talk about addiction as a brain disease or a chronically relapsing brain disease, is to talk about the fact that it is treatable and that most people will recover. So I think that's important to get across in the same sentence. So we don't just leave it by talking about the fact that emphasizing the biomedical nature, but the fact that they are treatable and that most people recover. So, Karina, do we want to take a break now? It's around about 11.
Sure, it's 11:03, so if we can take a 5-minute break and everyone be back around 11:09, let's say, that would be great.
Fantastic. Okay, great. Thank you.
Thank you. Hello, I'd like to welcome everyone back to the webinar. And Dr. Kelly, if you're ready, we'll go ahead and get started again.
Great, that's great. Okay, hopefully we'll have some time for questions at the end, so feel free to think of any questions or comments, and we can discuss that hopefully at the end, or as Karina has been doing, we can also, pitch me questions as we go along. So as I mentioned, these three ways that we can address stigma, education, personal witness, and language and terminology. I'm going to turn now a little bit to our focus on language and terminology in recent years. Now, in the addiction field, of course, we have a lot of different terms and terminology pertaining to harmful substance use. Some of them are here. Some of them are more commonly used than others. Many of them are used incorrectly, certainly in terms of their technical meaning. But many of these, of course, we're all familiar with. Also, people who suffer from the conditions themselves have different labels attached to them in relation to how these disorders are conceptualized. And that's what I've been talking a little bit about earlier in terms of how we conceptualize them does seem to, and how we label them does seem to reflect different aspects of stigma. Now, I've been focused in this area quite a bit, probably the last 15 years, looking at one of the areas of research that I've been looking into has been the effect on implicit cognition of different labels that we attach to people who have these conditions. Some of these are documented here. Substance abusers, addicts, substance misuse or alcoholics. Some of them are more pejorative. Some of them are more used in the general public or media. Others are more clinical. Let me pitch this question to you. People with eating-related conditions are always referred to as having an eating disorder, never as food abusers. So why are people with substance-related conditions referred to as substance abusers or drug abusers and not as having a substance use disorder? We never refer to people with eating-related conditions or problems as food abusers. We don't talk about the food abuse field. We always talk about it as the eating disorders field, and that people have eating disorders. Interestingly, when we turn to substance use, we historically have, for some reason, tended to talk about people with drug problems as drug abusers or substance abusers or alcohol abusers, and not as having a substance use disorder. Why is that? And again, I think it's related to this notion. Again, the rhetoric, the context historically around willful misconduct, and that people are engaging in this willful misconduct that unfortunately does produce substance use disorders, but it's tended to focus on using this pejorative terminology, which has stuck in our cultural habits and our cultural consciousness. But does it really matter? So this is the question that I asked myself many years ago now. Is it just political correctness and mere semantics? Is it really much ado about it? Who cares about language? Does it really have any impact, any bearing on how we think about things? Well, as I mentioned, this common terminology referring to people as drug abusers or substance abusers or alcohol abusers versus having a substance use disorder might actually, this is what I began to think, it might actually evoke different attitudes depending on the label, how we describe those individuals. For example, describing someone as a drug abuser or a substance abuser might actually imply that they're willfully engaging, they're choosing to engage in willful misconduct. In other words, they can help it and it is their fault, and therefore they should be stigmatized. Conversely, if you describe someone as having a substance use disorder, like they would if you had an eating problem, they would describe someone as having an eating disorder. If you were to use that kind of terminology, might you imply or evoke a more medical connotation, a medical malfunction, and therefore lead to more treatment-oriented approaches, more public health approaches, as opposed to criminal justice approaches, which you might use to address a substance abuser, for example. So what we did back in about 11, 12 years ago now, is that we conducted a couple of studies. In this first study, we randomly assigned, similar to the other study I just showed you, which we just published, we randomly assigned clinicians. These were doctoral level clinicians, mental health, psychiatrists, psychologists, working in the mental health and addiction field. So very well-trained individuals working in the field of mental health and addiction. And they were exposed at random to one of two different vignettes. In one set of vignettes, Mr. Williams, who was involved in a drug court situation and was required to maintain abstinence, but had relapsed and was up before the judge. In one of those vignettes, Mr. Williams was described as a drug abuser. In the other one, he was described as having a substance use disorder. Otherwise, they were identical. And those two vignettes describing the same scenario were randomly assigned to these 700 clinicians, doctoral level clinicians. What did we find? Interestingly, at random, those clinicians that were exposed to Mr. Williams described as a substance abuser versus having a substance use disorder were more likely to agree that he was personally responsible, to blame for his condition, and more in need of punishment, less in need of treatment. When we looked at this, a similar study in the general population of individuals, several hundred general public individuals, looking at these same two terms, we could see the difference was even larger. So when someone was described, for example, as a substance abuser versus having a substance use disorder, they were perceived here, as you can see, much less likely to be in need of treatment, more likely, substantially more likely to be in need of punishment, more of a social threat, more to blame, vastly more to blame, less likely to be exonerated, and more likely to self-regulate, to be able to self-regulate their drug use, so they are engaging in willful misconduct. Again, just by virtue of the label, which is very commonly used in our field. So what are the implications of that? Think about that for a minute. You know, just at random, even when we don't mean it, even when we have no intention of causing any harm, by using that term, drug abuse or drug abuser, we are actually activating an implicit cognitive bias that in turn activates a negative schema related to these problems. By using the term abuser, we are evoking the notion of more punitive action, more harsh, the policies of the war on drugs, as opposed to a broader public health approach and medical approach when we use other terminology such as substance use disorders. And I think we can learn, and of course we have shifted in the field overall. We are shifting. We're going through a change right now as I'm talking in terms of shifting our language to be consistent with what we have learned about the nature of these conditions and disorders in the last 50 years. And I think we should learn from our cousins in the eating disorders field who never referred to patients as food abusers, but rather people as having an eating disorder. When we think about our field, sorry, Karina, were you going to say something?
Oh, yes. We had a couple questions. Is this a good time?
Yeah, sure.
Okay. So they choose, this is a question, they choose to keep doing it even though they are negative consequences. It doesn't seem like there is a treatment per se, as more a choice by the addict to stop. So why call it treatable? Is it truly treatable in light of choice involved as well as the genetic disorder involved? Unlike other diseases, you have a disease and there are treatments for it that treat it without much of your own effort.
Yeah, let me see if I get the question. So the idea is that people with a substance use disorder have some capacity. I think it's related to capacity, cognitive capacity, to be able to make decisions about change. I think that's what the questioner is getting at. Yes, and again, this occurs on a continuum of severity. So we have mild, moderate, and severe substance use disorder. The kind of folks who end up in treatment are the folks who are unable. They're unable to stop it or stop it for very long. Again, like Mark Twain says, I've quit. Now, quitting is easy. I've done it dozens of times. Why is it that people cannot maintain a behavior change over time? And this in part, so much so that we get 100,000 deaths from alcohol every year and about 70,000 drug overdose deaths every year. So there is a malfunction in this organism. In the organism, there is a brain malfunction which causes this inability to prevent exposure, even despite good intentions. And this is what we're dealing with on the severe end of the spectrum. This is not to say that people cannot make decisions to get treatment and to get help or to try and stop. People do all the time. But this is, of course, a cardinal feature of substance use. It's repeated exposure despite harmful consequences, even to the point of premature death, roughly on average, as I mentioned, 30 years prior to Mother Nature intended for those who are sadly taken from us. But this is why it's very important to start the conversation earlier in terms of intervening, screening, brief interventions. Even if we don't see immediate changes in behavior, we are planting seeds earlier. What we do know is when you look back across time, the people who've got earlier interventions had that conversation started earlier. The time to remission is much shorter for those individuals. The course of the illness is less severe and less impactful. So this, just like other illnesses, if we address it earlier, people have more agency. They have more capacity to be able to make those changes before their brains are more radically impaired, which can lead, of course, to premature death. We see hundreds of thousands of people killed every year from substance use. So was that the only question, Karina?
The second question is, does the brain images, such as the ones you showed, do they look the same or similar for the brain matter that has been noted to change after even a few uses of opioids like Percocet and the like? Dr. Malik, who is a substance abuse expert, has indicated that observing anyone, even those without any genetic predisposition to addiction, their brains show permanent changes in their gray matter even after a few uses on a regular basis.
Yeah. I mean, again, the brain is neuroplastic, so it has neuroplasticity. It will change as a function of exposure to drugs, of exposure to many different things that we do. Even if you learn a new behavior, learn a new skill, your brain will change. Now, the question is it permanently damaged, or to what degree? It's a matter of degree of both neurotoxicity and functional change. So usually it changes in a dose-response fashion. So the greater the impact, the greater the neurotoxic impact, the greater the change. It doesn't mean that people cannot recover. People, of course, we do know that the individuals get into remission. 75% of people with substance use disorder achieve full remission. That's a good prognosis disorder. It can be a bumpy ride getting into remission, but people do remit. Now, not everybody gets the same, they don't get back what they've lost. They might get the majority of cognitive functioning back, but something is lost. And that the degree of loss in terms of cognitive capacity and cognitive functioning depends on how severely you've been addicted, how long you've been using, over what period, and a variety of other factors, including nutritional intake, age of onset, and other factors as well. Good questions, though, and I hope we'll have more time for discussion before noon. But let me just finish up here in terms of this issue of stigma and language. Here's another instance that we see in our field that we don't see in other fields. Language such as dirty and clean. Even at top places around the country, I've heard people's urine toxicology screens being referred to as being dirty or clean. We don't use that language in any other area of clinical care. It's street language that somehow made its way into the top levels of clinical care, or across all levels of clinical care. Now, I don't think we need a study to understand why it might not be ideal to describe somebody's urine as dirty or somebody themselves as dirty or clean. That hopefully is face valid, and something that I think in the field of addiction medicine that we need to drop in a hurry. We don't need studies on that. I don't think that's particularly helpful. I don't think many people would agree that using the term dirty is a helpful term. Again, this notion of language, what we're understanding is that certainly I've learned that surprised me how important language is. It's our way of communicating what we think and feel. It's a standardized set of symbols and sounds that really are the way that we communicate with one another all the time. And so our language is actually very important. It reflects and affects our approaches. We published this dictionary on Recovery Answers, which is our website for the Recovery Research Institute, about 10 years ago. And the idea here is that if we want addiction destigmatized, we need a language that's unified and that really clearly reflects what we've learned in the last 50 years around addiction and substance use disorder. And you can actually find this if you go to recoveryanswers.org. You can look up the dictionary and find there are several hundred terms there across the addiction vocabulary. And they have stigma alerts, which identify terms that have been used, that have been shown to be stigmatizing empirically. And it shows alternative terms that can be used instead. And this dictionary, I'm happy to say, has been adopted by many different entities around the world, including Google, who featured it on their Together Recovery is Possible page during Recovery Month, as well as the American Bar Association. Very happy that attorneys are now looking at language as an appropriate way. The Associated Press as well has published their style guide in 2016, which points out the stigmatizing language, how it's used, what not to use, what to say. This is very important when we think about the media, because journalists, and I was speaking to one this morning about this very guide and the importance of how in the media addiction problems are portrayed, how people with addiction problems are conceived based on language, and how that's they'll be making major shifts there. Also in the addiction publishing, so in publishing science, addiction science, I went and attended and presented at the International Society of Addiction Journal Editors in Budapest in 2015, presenting some of the information that I've been presenting to you today. And after that, they adopted a consensus statement which advocated against the use of this terminology in the published addiction literature worldwide. So to get rid of terms like abuse and abuser and dirty and clean out of the vocabulary because it's shown to be stigmatizing. What we are doing right now in an attempt to again, change the language and make it more unified, to make it more accurate, to make it more consistent with the research coming out of our National Institutes of Health, is to actually change the names of our National Institutes of Health. Ironically, it's ironic that we have still embedded in our National Institutes on Addiction, that is to say, the National Institute of Alcohol Abuse and Alcoholism, the National Institute of Drug Abuse, the Substance Abuse and Mental Health Services Administration, SAMHSA, and the Center for Substance Abuse Treatment, all have in their names the term abuse, which we now know has negative connotations. It induces these implicit cognitive biases as well as explicit cognitive biases, which undermine the very efforts that they're trying to actually propagate, which is to public health efforts and to reduce stigma and discrimination. So we are working right now through the Action Network, and if you're interested in supporting this initiative, we are trying to change the names of the National Institutes on Addiction, all of those names, to adopt new names which have shown to be less stigmatizing, more neutral names, and remove the term abuse. So we are we're creating this petition at Action Network. If you want to sign up, please do. Go to theactionnetwork.org, and these are the hashtags, change the names and the stigma that we're trying to do to change that. So in terms of recommended language examples, the idea here is to not use the kind of language and terminology that we've now found to be pejorative and stigmatizing and more punitive, like drug abuse or alcohol abuse or substance abuser. And instead, like in the addiction, in the mental health field, they've been way ahead of us in the addiction world in using respectful language, using person-first language, as they say, not describing someone as a schizophrenic or depressive, but rather as someone who has schizophrenia or suffers from schizophrenia, or a person with schizophrenia. And again, the idea here is to use the same person-first language with individuals with substance use disorders. So it's a person or an individual or a patient with a substance use disorder as opposed to a drug abuser. Again, with alcoholic, again, a common term. It's embedded in our cultural consciousness. It takes a while for all these things to change. I realize that. We all realize that our language is habitual, and it takes time for these things to shift and change in our behavior and also our cultural psyche. But again, instead of describing someone as an alcoholic or suffering from alcoholism, to actually use more accurate, up-to-date terminology, describing them as a person or individual with an alcoholic disorder. Again, dropping dirty and clean out of the vocabulary, it should be a no-brainer. We should not be referring to individuals as being dirty or clean or having dirty or clean urine in any public health or clinical setting. And again, with heroin or opioids, again, using person-first language to document and describe individuals who suffer from these conditions. I heard Karina mention that you have access to all of these slides and references. Feel free to email me if you want more, any of these studies. I'm happy to email them to you. And these are other resources here that you can go look at if you're interested in more about how to reduce stigma through these different pathways, including through terminology. And just a final, before we go into questions and discussion, just to thank you very much for having me and for your attention. And also to let you know that we do publish a free monthly bulletin on all the recovery, treatment and recovery science that's coming out every month. We publish this monthly bulletin through recoveryanswers.org, and you can sign up to get it in your email box every month if you want. It's the idea is that we translate, synthesize, contextualize the latest science on addiction, treatment, and recovery, and make it usable for clinicians, policymakers, as well as for the general public. And you can sign up at recoveryanswers.org. It's completely free. Thank you so much. And Karina, do we have any other questions or discussion?
Yes, we do. Thank you. The first question is, what are your feelings about offering leave behind Narcan in conjunction with offering buprenorphine MAT? there seems to be varying opinions as to whether it enables undesired behavior or helps.
So what enables undesirable behavior?
It says, how do you feel about offering leave behind Narcan in conjunction with offering buprenorphine MAT? Because I guess there's varying opinions as whether it really helps or enables.
Yeah, and good questions. Yeah, I think you have to look at the data, look at the overall. There can be some individual cases that where you might find anecdotally that certain people will be misusing that offering, that potential. On average, though, when you look at it as a public health effect, public health benefit, when you utilize these strategies of making medications easier to get, Narcan easier to get, buprenorphine easier to get, yes, there is some diversion with buprenorphine. We have to be very cautious and careful that people and do what we can to prevent misuse and diversion. But overall, we can see that these medications actually save lives. Narcan obviously does, because that's an opioid overdose reversal medication. But providing naltrexone, injectable naltrexone, buprenorphine, we have now Sublocade, a longer-acting buprenorphine via a 30-day injection, which is shown to be just as effective as oral buprenorphine, as well as methadone for those who don't respond to buprenorphine. Very effective in terms of reducing overdose by 50%. We don't get that magnitude in virtually any other area of medicine. That is a huge positive effect. If we can prevent somebody from overdosing and dying, that gives them a chance at recovery, and that's why these things are so important. We have to look at it from a broader public health approach, even though we might come across anecdotes where we see misuse and diversion.
Okay, we have another question. Do you recommend, oops, it just moved. Do you recommend using remission to replace relapse?
Well, remission was the opposite of relapse, right? So, if I think maybe they mean recurrence. Do they mean recurrence as replacing relapse? There's been a push to replace the word relapse in some quarters because some people feel that the term relapse is stigmatizing, and so there's been a push by some individuals. I haven't seen studies on this per se, that using the term recurrence, like is used in other kinds of health disorders, a recurrence of symptoms as opposed to a relapse. Some people have advocated for the term recurrence, a recurrence of symptoms or a recurrence of use as opposed to relapse. So that's one area that's been advocated for. Remission, though, I think remission on the plus side, of course, that implies being symptom-free, so having no symptoms. And I don't think there's any controversy around the term remission on the positive side of things. So that generally has been viewed as being a positive. Yep.
Okay. Would you suggest correcting patients when they use stigma language against themselves?
Well, I think what we can do is model. I wouldn't necessarily correct somebody, but I would, depending on my relationship with them, if I was in a therapeutic relationship with somebody, I might point that out at a certain point. But I think what we can do is we can certainly correct ourselves in modeling the terminology that we use in clinical and public health settings. If someone calls themselves a drug abuser or an addict, we can not use that language ourselves and refer to them as having an opioid use disorder or an alcohol use disorder, as opposed to being a drug abuser or a drug addict, or a person who suffers from addiction or from a substance use disorder. So I think we can model that. I'd be careful about, depending on the rapport, the amount of rapport I built with somebody, whether that was the right thing to do to point out. You'd have to judge that based on your own kind of relationship with the person. But I think overall, we can model our patient's behavior by utilizing non-stigmatizing language ourselves.
Thank you. What about if you're a person sitting in a NA or AA meeting, or you were running the meeting? Should you say, "Hi, I'm Jane and I'm an addict," or "Hi, I'm Jane and I'm a person with a blank addiction"?
Yeah, I think for people themselves, I think they have the freedom to describe themselves however they want. I think I think eventually that language will change and that self-reference will also change. But I think that's going to take time. Again, all of these cultural shifts, our language is habitual. We're comfortable, many times we're comfortable with our language and it's habitual. We don't have to think about our language. It tends to come very quickly and very naturally. We actually have to stop and think and to change our language. But I think in terms of people themselves, I think they have the license and freedom to refer to themselves anywhere they want. I think the issue is for us in the clinical and public health realm, if we know that certain language is stigmatizing, we don't want to be using that language, period. We do not want to be propagating, modeling it. We want to be using language that we know does not induce negative biases towards individuals who suffer from these conditions, but rather are neutral or have a positive effect. So our responsibility, I believe, is to model those changes. Eventually, again, language changes. We don't refer to psychiatric hospitals as lunatic asylums anymore. We call them psychiatric hospitals. So our language does change, but it can take time to change. The point is that if we know that language is stigmatizing for these very stigmatized conditions and stigmatized individuals, we need to model that change.
Okay, thank you. A comment and a question. It is very hard for family to watch an individual slowly kill themselves via a severe substance use disorder. Do you have any advice or tips for how to encourage the severe addict who has been using massive amounts of alcohol for 20, 30, 40 plus years?
Yeah, well, this is a huge problem, huge problem, and it's so distressing. I can sympathize with the questioner in this area, and many of us probably have experienced this who are here today or experience it clinically, to see someone deteriorate who has an addiction problem. Ultimately, of course, it can at any time increase the risk for premature death. There is, thankfully, things that we can do now. One of them that's very potent, that's come along in more recent years, is the CRAFT intervention. Some of you may know about this. It's called the Community Reinforcement and Family Training Program. And it's a powerful, empirically supported intervention to help concerned significant others, that is to say family members or friends who are in close proximity and close contact with the individual who's addicted but doesn't want to get help, to get help. And really what it does is that it alters the contingencies in the environment via your own behavior, your own vocal behavior, your own actual behavior in what you say and do with that individual, so that you do not reinforce substance use, rather you alter and shift that dynamic in the relationship that makes it substantially more likely that individual will get help. The good news is there's lots of now randomized controlled trials which show that this actually works. And it's called the CRAFT intervention, Community Reinforcement and Family Training. If you look that up online, you can find these interventions. You can even find training protocols. You can find online courses that you can actually take and educate yourself through this process at home to give yourself a chance, empower yourself to make those changes at home that makes it more likely for that individual to seek help. There's also a book published by Hazelden, I believe, called How to Get Your Loved One Sober Without Nagging, Complaining, something else. But that's another book, a self-help resource based on that CRAFT program.
Thank you. Isn't methadone therapy most effective in combination with counseling or psychotherapy?
Yes, the best practices for methadone is in combination with counseling, at least once per month. So it's been shown to be optimally used when you have counseling along with it. Importantly, for many people, they also need case management. So when you add case management, in other words, helping people to get connected to employment, to other kinds of training activities, education, housing, all of these other factors, what we call the social determinants of health. Case management can add in addition to counseling and psychotherapy. But all those can be very valuable for individuals who have severe opioid use disorder who are on methadone, and there's lots of good evidence to support that.
Okay, so I have another question. How is it that if you drink bleach or arsenic, certain things will definitely happen to your body, but yet a person who has drank hard liquor, like a fifth of the bottle every other day for 20 or more years, may not show any or minimal health impact to their body? How is that possible?
Well, it's very unlikely that someone will show no detriment as a function of exposure to that amount of alcohol, because alcohol will deleteriously affect all kinds of body tissue, particularly the liver, the esophagus. It increases risk of cancer in the esophagus, larynx, pharynx, and liver cancer also. So now again, there's a lot of individual variability, right? We know that, we've all heard of somebody smoking 4 packs a day and they live till they're 90, or they drank 2/5 a day and they're in their 80s. We hear of those cases, but it doesn't mean that they're typical, even though you can find anecdotal cases like that, which stand out, of course. They stand out because they're very unusual. The more typical course will be if you are drinking that amount of alcohol, that amount of exposure, your liver is going to be very severely damaged, if not cirrhotic. You're at increased risk for death from accidental injury, let alone toxicity-related illnesses. Your brain is going to be affected. If you were to do a brain scan with that individual, you would see functional and structural changes in the brain of that individual. So there are things, on average, you might see individual variability. Some people have robustness, a strong constitution, quote unquote, which can protect certain people from these deleterious effects. But on average, what we see is definitely those toxic effects on the human body and brain. 100,000 deaths per year from alcohol alone.
I don't see any other questions. There is a comment. I think providers who prescribe MAT, such as methadone, need to be held accountable for checking levels to make sure they are not overusing. Just want to hear your thoughts on this, being a doctor.
Well, I'm a clinical psychologist, so I don't prescribe myself. I am a doctor of psychology. But yeah, I think absolutely. I mean, good practice would involve caring for your patient. That means you want your patient to get well, not worse. We do know that methadone, buprenorphine, naltrexone for opioid use disorder really helps people. It can prevent death, which is so key when we think about giving someone a chance of getting into recovery. But yeah, you've got to take care, in other words, and responsibility to help your patient understand that they're taking a full agonist, that there is potential for misuse, for diversion, and to help them stay on track, because we want to help people, not hurt people more. We don't want to keep them stuck. We want to get them into remission, and that's really the goal. So absolutely right. We need to be monitoring their use of methadone or other medications that they're taking to make sure that they're not perpetuating the illness and not harming themselves or other people.
Thank you. Is methadone another addiction at times? And then also, if you could please provide the name of that book again so that I can post it. We have people asking.
Oh, yeah, the Hazelden book, I think it's called How to Get Your Loved Ones Sober. Let me just, here it is. It's How to Get Your Loved Ones Sober, Alternatives to Nagging, Pleading, and Threatening. And it's published by Hazelden. How to Get Your Loved Ones Sober, Alternatives to Nagging, Pleading, and Threatening. It's about, and you can get it for anywhere from a few dollars up to $10 by the look of things. Okay, Karina, you got that?
Yes, I just posted it for those who were asking. How do you see the use of peer recovery specialists and their benefit?
So let me just answer the methadone question. So as well as answer this question, peer recovery support specialist. The methadone question in terms of addiction, I think it's important to make a distinction between addiction and dependence. You know, historically, and this hasn't helped in the field because we've historically used the word dependence to refer to addiction in the DSM up till DSM-5. Dependence was used as synonymous with addiction. But we can distinguish between addiction and dependence, I think, and it's helpful to do so. People can be dependent on methadone without being addicted to methadone. So you can be dependent on these medications that would produce physiological withdrawal if you were to stop them, but it doesn't mean you're addicted to them. You don't show an addiction syndrome to methadone, in part because it has this long-acting effect. So I think that's an important distinction to make, the distinction between dependence and addiction. You can be dependent on methadone, you can be dependent on buprenorphine, which means you'll produce withdrawal. You have to taper off gradually and slowly to reduce distress, but you're not addicted in the same way as you'd be addicted to heroin. Go out and drugs, seek it, and use it, and continue to use it despite harmful consequences. So in terms of peer recovery support specialists, the question was, are they helpful? Do they, what evidence do we have? Was that it, Karina?
How do you see the use of peer recovery specialists and their benefit?
Okay. Yeah, so they can be used in multiple different contexts and ways. We know that the lived experience that peers in recovery have is very powerful. It's immensely helpful in building rapport quickly, increasing credibility, instantly, because people who have that lived experience have instant credibility. And they can help build rapport quickly when you can say, look, I've been where you're at, I've had what you're at, I'm over, I'm in recovery now, I want to help you. That's so powerful. And so this is why there's been such a growth in peer recovery support services. We've got a lot of evidence of mutual aid. So groups like AA, as I mentioned, AA, NA, Smart Recovery, LifeBring, these myriad of different organizations which are based on that lived experience, that peer support, have been shown to be very powerful in terms of helping people achieve and sustain remission over the long term, particularly regarding the research on AA that's been done. So that's the good news, is that they are effective. Peers are very effective and very cost effective also when they're utilized to help people achieve and get into recovery, become engaged and get into recovery. We use them where I work at Massachusetts General Hospital. We have about 15 recovery coaches, they're called, but they're peers in recovery who are there to link patients, to build rapport at the bedside when people come into the inpatient or emergency department, to link up with the recovery coach with lived experience to get them connected and engaged and linked to the next set of services. So that's one way that peers in recovery are being used in general medical settings like ours at Massachusetts General Hospital. They're also being used across the board, a range of different recovery support services in collegiate recovery program, in recovery high schools, in recovery community centers. We're doing a big national project now in recovery community centers. So these are centers where people can come and build recovery capital. They can get access to jobs, to employers, to training, to education, to other resources, to childcare for people who are starting a recovery journey. And they're filled with peers in recovery. They can get access to recovery peers and recovery coaching in those places. So those are some of the places where recovery peers and peer support specialists are being employed and deployed to help people, again, engage in, retained, and helped in recovery. And I think even though the evidence base is still a little bit lagging behind other areas, we're going to see much more of that in the next 20 years in terms of more rigorous trials looking at this, which I would put money on. We're going to show effectiveness and cost effectiveness in the same way that's been shown for AA.
Thank you very much. I know that there's some of you that still have questions out there, so I have posted Dr. Kelly's email here. If we did not get to your question today, please feel free to email him with your questions. And Dr. Kelly, I did want to thank you for all your time today. Your information was very helpful to our audience, and we do appreciate you presenting and giving us your knowledge and insight to substances and stigma. And I do want to also thank our audience for attending today. And I do have a few housekeeping items that we need to go through. Once we conclude today's webinar, your browser is going to take you to an evaluation on FADA's website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. Your feedback is very important to us. You will be prompted to register or sign in to complete the evaluation, and you can register as a visitor at no cost. For CEs to be reported to CE broker, for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number for the first time you register. After you register or sign in, you'll be directed onward to the evaluation, and you want to use the same email address that you used when you registered for the webinar so that we can connect your attendance to your profile. You will also get a second opportunity to complete the evaluation through a follow-up email today. If you have created a profile on our site, you will receive a thank you email for attending today, and the sender will be from WebEx. So one other thing to note is the evaluation does close on Friday, December 4th at midnight. So please get your evaluations completed then. Also, we do not email statements of credit. Instead, after we verify your attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Again, this process can take up to 30 days, so please be patient. Once you, after the 30 days, or typically we get it in before the 30 days, you can look in your profile that you've created under Manage Profile, Content and Features, and under Professional Development. So once your attendance and evaluation is verified, it will be posted there. So Dr. Kelly, we thank you again for presenting, and we also want to thank you for participating in today's webinar, and we'd like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Did you have anything else you wanted to add, Dr. Kelly?
I just want to say thank you so much for having me. It's been a pleasure, as always, to come and speak with you all today. Thank you for coming, and thanks for having me, Karina. Appreciate it.
Okay. Thank you very much. Have a great rest of your day, and please hold for the evaluation. Thank you.
Thanks, everybody. Thank you.